All right, guys. So it was 5 years ago that I was sitting on that side of the table, and it definitely feels a whole lot different to be up here in front of you today. So before we kind of get into the actual content, I want you to reflect on your readings, and keeping in mind that the human body functions as a whole system. I want you to do a 1-minute paper that talks about what are the serious problems that STIs can cause to one's health. Okay, so I'll write it up here so you have it. But what serious problems? Like long-term things that we're thinking of, STIs cause to one's health. Okay, if you want to hand those up. Thank you. No, it's great. Thank you. Thank you. Okay, thank you. So I want to begin by highlighting the state of our sexual health in the U.S., okay? So the STIs remain a major public challenge in the U.S., with approximately 34% of Americans actually having an STI. It's a pretty significant statistic there, right? So it's obviously an ongoing hidden epidemic. There's a total of 110 million Americans that have an STI at any given time. And like we said, that's 34% of the population. And half of all new infections occur in young people, ages 15 to 24. So how can we play a role in preventing and reducing transmission? So, I mean, in healthcare, it's all about preventing and educating, right? So we can talk, we can test, and we can treat. So we want to talk openly about STIs with our partners and our healthcare providers. We want to get tested. It's the only way to know if we have an STI. And we want to treat. If there is, in the event that there is an STI, we want to get the right medication in a timely fashion. To teach our proper male and females, so teaching, the component we talked about is important. We're going to talk about condoms, limiting the number of sexual partners, educating and recognizing the signs and symptoms of the STI, and always using a condom, even with oral and anal sexual contact. And if the STI is suspected, then we're abstinence from sex until it's treated. So it's really significant. The age group that we really are most concerned about are young adults, because a lot of these STIs have lifelong issues that we have to deal with, and they are at risk. So the CDC estimates that the youth ages 15 to 24 make up just over 1/4 of the sexual active population. But they really account for 20 million new sexual transmitted infections that occur in the US each year. So unique factors that place our youth at risk include insufficient screening. So they don't receive the recommended screenings. The confidentiality concerns. They're nervous to talk to their healthcare providers about these things, and probably many of them won't speak to their parents or their guardians about these either. Their biology makes them susceptible. The lack of access to health care. They may not have insurance, or they may not have transportation to get to these preventative services. And at these ages, they may engage with multiple sexual partners. So talking to our young adults about STIs in an area where we as nurses can provide guidance to parents is really essential. So this video talks a little bit about that.
I'm Kelly Warner. In the last 5 years, Lane County Public Health has seen an alarming increase in sexually transmitted infections. And according to the American Academy of Pediatrics, about 25% of teenagers will have an STI before they graduate from high school. That's why healthcare providers say it is more important than ever for moms and dads to start an important conversation.
As a pediatrician, Dr. Bradshaw helps parents start sometimes uncomfortable but important conversations with their teens, including preventing sexually transmitted infections.
The problem with most sexually transmitted infections is that you have the contact and then you have the infection, but you may not have any symptoms at all. And yet you're highly contagious, and if you're out and about in the community, you're spreading it.
According to public health, the number of syphilis cases across Lane County has increased 1,100% in the last 5 years. Gonorrhea cases are up 600 to 700%, and HIV cases a 50 to 60% rise since 2012. Find appropriate moments to talk about sex and its dangers when you have your teen's attention, like in a car or while watching a relevant TV show or movie.
So, what did you think of that? What did you take away from this? Start the conversation that way. The bottom line is, this is not about the birds and the bees talk. It's not about a single talk. They can't just hear things one time and change them.
Dr. Bradshaw reminds parents not to assume teens will make safe choices on their own. Instead, to teach them.
It's much, much, much better to talk to your child about preventing sexually transmitted infections. Please don't just talk to them about abstinence. Talk to them about that first, hammer that home, but do not put your head in the sand.
According to national surveys, teens say their parents have the greatest influence over their decisions about sex, more than friends, siblings, or the media. For more information on talking with your teen about these topics, check out eugenepeds.com/healthykids.
So just reflecting on that video for a minute and a lot of the data that was in the beginning of the presentation, why are we so concerned about this age group? So what are the results of some of these infections that they may contract unknowingly? Infertility, lifelong health consequences. Okay, probably a lot of those things that you were thinking when you did your 1-minute paper in the beginning. This is a huge group that's at risk. They're young. They're of childbearing age. So it's not just them, it's their children as well that can suffer the consequences of a lot of these STDs, STIs that we're going to talk about today.
Okay, so we're going to turn our attention to other groups that are at risk, increased risks for catching STIs, and this is called health equity. Basically, this is where everyone has an equal chance to be healthy regardless of your background. What does this have to do with STIs? Well, research shows that there is a higher rate of STI among some racial and ethnic minority groups compared to Caucasians. It is most important to understand that these higher rates are not caused by color or heritage, but by social conditions more likely to affect minorities. So these factors would include like poverty, large gaps between the rich and the poor, few jobs, low education levels. This can make it more difficult for people to stay healthy sexually. So people who cannot afford basic care needs, they have trouble accessing quality health sexual services. There also might be distrust in the healthcare providers, negative feelings around STIs, and communities with high STI rates also factor into this health equity equation. So specifically, the Healthy People 2020 defines this as the attainment of the highest level of health for all people, regardless of their racial ethnicity, income, gender, religion, sexual identity, and disability.
So does everybody understand what health equity means?
So it's equality for health, right?
Right. And so why would these things like race, ethnicity, income, gender, religion, why would those create an unequal advantage when it comes to healthcare, specifically sexually transmitted infections? Cultural stigmas.
Communities they may be based in, right? They might not have access to a lot of these services.
Makes sense?
So with the health equity specifically, we'll speak about women first, okay? So women disproportionately bear the long-term consequences of STIs. For example, each year, untreated STIs cause infertility in at least 24,000 women in the US. And untreated syphilis in pregnant women specifically results in infant death up to 40% of those cases. So other harmful effects of the STIs in babies include stillbirth, low birth weight, brain damage, blindness, and deafness. The women's anatomy can place them at a unique risk for the STI infection compared to men. Women are less likely to have symptoms of the common STIs compared to men. They may not see symptoms as easily. STIs can lead to serious health complications and affect women's future reproductive plans. So we talked about infertility long term. Women who are pregnant can pass STIs onto their babies. So HPV is the most common STI in women and is the main cause of cervical cancer. Minorities, when we're speaking about health equity, surveillance data shows higher rates of reported STIs among some racial and ethnic minority groups. So because of this, or they have fear and distrust in the healthcare institutions. Race and ethnicity in the United States are population characteristics that are correlated with other fundamental detriments of health status, including like income inequality, unemployment, low educational attainment, and high rates of poverty. These inequities in social and economic conditions are reflected in the profound disparities observed in the incidence of STIs among some racial and ethnic minorities. So again, in communities where STI prevalence is high because of the inequalities individuals may have, they're more difficult reducing the risk of infection. So here are some statistics, specifically for chlamydia. You see that women are higher on the chart here. The first one is American Indian, Asians, Blacks, Hispanics, non-Hawaiian, other Pacific Islanders, whites, multi-race, and the total. Same thing here for gonorrhea rates. You see that those are high in American Indian. Syphilis is higher in men. So it is important to know, though, that not all vaginal infections are considered STIs, okay? So before we get kind of into this discussion, it's important to differentiate the two. So we have bacterial vaginosis and candidiasis, which also known as yeast, are two common vaginal infections. Women often confuse the two because sometimes they present with the same symptoms, specifically like a foul discharge, which can sometimes lead to self-diagnosis and then not treating properly. So bacterial vaginosis is the most common vaginal infection in women. Although it is not an STI, it is sexually associated, okay? It results in a lack of lactobacilli, which helps to maintain that vaginal low pH level. So a normal vaginal pH level range is like between 3.8 and 4.2. So there is a lack of this that causes the clinical manifestations. Sometimes can be asymptomatic, a white-gray discharge, a fishy odor. Symptoms worsen after intercourse. So to diagnose this, we do a whiff test. It's a potassium hydroxide on the discharge. Like you literally you can smell, it comes off with an odor. Or you can do the clue cells on a wet mount. And treatment for this is flagyl, which is contraindicated in the first trimester and while breastfeeding.
Can you keep it?
Yeah, yep, thanks. Just let me know when you want me to advance it. The bottom one there is clindamycin or cleocin. It's a little cut off, but.
You said you're gonna post this after.
Yes. Yes. You will have the link to the Prezi on Blackboard under week 15. Good to go? Flagyl and cleocin or clindamycin.
So yeast infections or candidiasis are associated with antibiotic use, corticosteroids, and uncontrolled diabetes. So the clinical manifestations that we'd see here with yeast infection is this intense pruritus, this itching, irritation, thick white cottage cheese-like discharge. Again, it's going to be a wet mount, but it shows budding of yeast. And the treatment for this are antifungals, available in the cream and suppository form. They're not all well absorbed systemically, therefore they're considered safe during pregnancy, okay? And there's also over-the-counter antifungals that are available. But you know, it's important that we're not self-diagnosing, so that we're consulting with our provider when we do have symptoms like this. So we are going to move on to STI infections, okay? This is the list here. The first one that we're going to discuss is chlamydia. So chlamydia is the most common STI in the U.S. It is the leading cause of preventable infertility and ectopic pregnancy. 1 in 10 teenage girls with chlamydia, currently in the U.S. It is transmitted through vaginal, anal, and oral sex. It is considered the silent disease because upwards towards 75% of women don't know that they have it. Chlamydia has the potential to be transmitted to the newborn during delivery, causing conjunctivitis and pneumonia. So during your time on the L&D floor, do you remember what medication is used? Yeah, okay. The key to treatment is that both partners are treated, okay? And that they should not engage in sexual activity until at least 7 days of treatment has been received.
You need to star that on your packet. The key is that both partners are treated and that they're not having sex with anyone, including each other, until the treatment is completed.
You'll see that's a common theme with a lot of these. Did you guys get that? You need to repeat it? 7 days. So with chlamydia, it could be mostly asymptomatic, 75%. That's why it is called the silent disease, okay? In men, the same as men and women. For diagnosis, the cervical vaginal swab, and a treatment is the azithromycin or the doxycycline. So next is gonorrhea. This STI is most prevalent in African American women ages 15 to 19, with the rate of infection being 15.9 times higher than in the Caucasian women of the same age group. Again, like I said, a common theme, making sure that both partners are treated, okay? Again, for some reason, women are commonly asymptomatic. Vaginal discharge, bleeding after sex, a backache, dysuria, urinary frequency. So to diagnose this, there is a targeted screening for those at the highest risk for infections: oral, anal, and pharyngeal, cervical, and urine. And that's the NAT, the N-A-T-T, N-A-A-T, I'm sorry. And again, treatment antibiotics there.
Is it normal for women to have vaginal discharge? Is it normal for men to have penile discharge? No. So, do you see why it's a little bit more easier for men to recognize these symptoms? Because if that's happening, they know something's wrong. We have to do like a microscopic analysis of our vaginal discharge to know that something is wrong, okay?
So do you recommend us making a medication card to these meds or?
What was the question?
Medication cards.
Or no?
For the treatments?
The medications?
No. Good question.
If you had to really know the medications in detail.
She wanted to know if you had to do a med card for the treatments. I would be familiar with which medications are used to treat each STI. A lot of them are similar, so it shouldn't be that difficult, but I would be familiar with that.
Okay, trichomonas. It is the most common curable STI in the U.S. Okay, it's actually a parasite. It's pretty cool to see on a wet mount. It looks like a dancing little worm. Okay, they wiggle on the wet mount.
You said it's the most common curable. Is it the most common one and it's curable? Or
The most common curable.
so
So not the most common,
okay.
but just.
curable one.
Of the ones that can be cured.
Information change your opinion on Trek?
Do we have to know the microbiology of it all?
You guys. No, I just think it's really cool that it's a parasite and really gross. And that you could take that information home to your at-risk teenager and say, did you know that this sexually transmitted infection is actually a parasite? That if you put it under the microscope, it moves around like a little worm.
There's like a trick dance is what they call it. So that's what you see on the mouth.
You guys are on the right place. I'm just saying.
But another, like a reoccurring theme again, simultaneous treatment with partners, okay? Maybe asymptomatic. Most times there's a frothy gray, green discharge with a foul odor, like a really distinct odor. And what we call a strawberry cervix. So these small red ulcerations on the vagina. So we do a wet mount that shows the trick parasites, a culture, the NAT, and the trichomonas rapid test. So treatment for this is flagyl.
What was a what now? Sorry,
Like you have like your slides, and you have to put a little liquid out, before you put the sample on. Okay, an oldie but a goodie, right? Syphilis. This is one of the oldest known STIs. May be contracted sexually or congenitally, and without treatment, it leads to severe disease and death. Incubation period is anywhere from 10 to 90 days, with the average being roughly around 3 weeks. So there are 3 forms or 3 stages of syphilis. So you have your primary, where you see this chancre. It begins as like a macule, which erodes. It becomes clean-based, painless, indurated ulcer with smooth, firm borders. It resolves in 1 to 5 weeks. This is highly contagious.
Do you think you would notice the statistics are unnoticed in 15 to 30% of people?
Oh my gosh.
I think I would notice if I had a shaker.
That's terrible.
Oh, sorry. You're waiting for me to forward the slide. I'm just.
Oh, that's okay.
Shaker.
So in the secondary syphilis, 6 weeks to 6 months after the chancre appears, then you might start developing these symptoms of fever, sore throat, weight loss, skin rash on the trunks and the extremities, a headache, generalized malaise, mucus patches on the genitals and mouth, flat warts on the genitals and anal areas, Resolves spontaneously in 2 to 10 weeks, still needs to be treated.
Is this scaring anybody else?
Oh my God.
That's pretty horrible sounding, right?
Wait, so it goes away?
Yes.
Chancre.
Is it in the first or the
Yes,
second?
that's when it appears.
Okay.
Chancre's primary, so the chancre heals and goes away, and then they get these like general flu-like symptoms. You're like, okay, I have this sore I didn't notice on my genitals, and now I have the flu, and the whole time you have syphilis, and you didn't even realize it. Scary. And then this happens.
Oh, that's awesome.
Yes. So this is the tertiary. 1 to 10 years after the initial infection, okay? Neuropathic joint disease, neurosyphilis, cardiovascular syphilis, tumor-like gomas, abnormal gait and inability to walk, numbness in your toes, feet, and legs, problems with thinking such as confusion and poor concentration, mental problems like depression, irritability, headaches, seizures, stiff neck, incontinence, tremors, visual problems. It sounds horrible.
Are you gonna get in trouble if I just do? Because, isn't this insane? So those holes in their skin is the tumor-like gumas. And I used to have a whole section in here about people in history that were thought to have syphilis. And it included Al Capone, Hitler, Van Gogh. Did you ever see that self-portrait he did of himself? It looks just like that lady. His skin is all, because there was no cure for this. And people, it's not like a debilitating symptom until it's 10 years down the road. And, believe it or not, so they test prenatally for this. They test the baby for this after it's born. And they test mom immediately after delivery, RPR, the rapid plasma reagent test. That's done at all those 3 points because Tess mentioned congenital. This can be transmitted to the baby, okay? So the baby can be born with congenital syphilis. And, we're like, Al Capone, Hitler. You should look on the CDC website sometimes if you ever want to be like astounded and disgusted, because the rates of syphilis in some states in the United States is astronomical. I went to a maternal newborn conference in New Orleans in September, and a lot of the people were from the surrounding areas, like big hospitals, like Baton Rouge Women's Hospital. They do like 6,000 deliveries a year, and they see congenital syphilis on a regular basis. Their syphilis problem has allowed them to be designated special funds from the state because their rates are so high. So it's not like a historical problem or something that's been eradicated. It is still very present and alive. So look out.
It is this content that makes me so happy that I'm married. I don't have to do that anymore.
So to diagnose, there's a dark field illumination, okay, there's blood tests. What Steph just talked about was the rapid plasma, the RPR. Okay, there's a venereal disease research laboratory, and there's the syphilis health check. Treatment for this will be penicillin G or doxycycline.
Can this go away? Can you get rid of it?
Yeah.
Get rid of it?
If you take the antibiotics, you can get rid of it. Depending on how long you had it, you may have some lasting symptoms from it. What?
That was my question. Is it so? Do you get those symptoms 1 to 10 years after if it's untreated only?
Yes.
Okay.
Yes. If it's untreated, you can develop those symptoms. But, some of those initial, the primary and tertiary, it showed a chancre on a woman, which that might not necessarily be, visual to you just looking externally. I think that's where the confusion kind of comes in, and it's a painless sore. It looks painful, but they say it's not. Never had a chancre.
You might not ever be aware that you ever had, the very primary stage of it.
Right spot.
No.
Love this about here.
So next up is herpes. This is transmitted through direct contact, usually during asymptomatic shedding period, okay? So it's horizontally shed from the skin, fluid, and secretions. Clinical manifestations, the primary infection may be asymptomatic. And then sores may begin as vesicles that become painful ulcerations. You might develop flu-like symptoms, prolonged systemic manifestations, reoccurrence of this potential with subsequent outbreaks being more severe. So it can lay dormant in the system and come back and reoccurrent, right? The diagnosis is the lesion culture, or the PCR, which is the polymer chain reaction testing. Treatment for this, you might have seen these if you were in the hospital, specifically on the maternity floor. A lot of our moms will be prescribed the acyclovir, the Valcyclovir. Valtrex is the other name for it. Okay, so if they have any kind of HSV on their history, they'll be prescribed that during pregnancy.
Why would that be?
Right.
Right? If they have any active lesions at the time of delivery, they would not be a candidate for vaginal delivery, okay? So they kind of give that as a suppression therapy, even if they're not actively having an outbreak.
Okay, so HIV and AIDS. Transmission and screening, because individuals between the ages of 13 and 24 represent greater than 25% of newly contracted HIV infections. That's why it's so important, okay? Most are unaware they are infected, as they are asymptomatic for years before AIDS develops. It's super important as the RN to know when screening for HIV is important, okay? So we need to inform the clients of the implications of a positive test. General medical consent for treatment is acceptable. A separate consent form is not a requirement. There are New York State approved centers for anonymous testing in which mandatory reporting would not apply unless the individual agrees to it. There are at-home HIV screening kits available. All pregnant women should be screened for HIV, and some providers will do it twice during a pregnancy. Something really important as the maternity nurse that we look for is the screening for the HIV, and then we do a specific HIV form that goes in both sets of charts, the moms and the babies. Every client should be screened for the HIV at least once. In presence of other STIs makes it easier for an individual to contract and transmit HIV.
Why would that be? Possibly. What else?
Who has other STIs might have HIV.
Think about those slides we just looked at. What did you see on there? Open areas on the skin, vesicles that are draining fluid, okay? So there are more areas of broken skin or compromised skin or more bodily fluid contact, okay?
Okay.
Not
So
done yet.
lastly is the HPV, which is another one of the most common STIs that we see here in the U.S. There are many types of this. HPV is transmitted during skin-to-skin contact, not specifically sexual intercourse. So the clinical manifestations, there are more than 100 types and over 40 strands can infect the skin. That part's cut off though. And only
Sorry.
one, what does it say?
There's only a specific kinds that cause cervical cancer, so you don't need to know the specific numbers of them, but the strains are numbered. There's certain number of strains that cause genital warts. There's certain number of strains that cause cervical cancer. So that's what it says underneath the picture.
Okay. So common warts, plantar warts, skin cancer, and genital warts.
Respiratory papillomas.
All right, genital cancer and cervical cancer, all types of the HPV. Most strands produce no symptoms. So a diagnosis would be the Pap test, followed by the serum, the HPV DNA testing. Treatment, there is no cure. Symptom management and prevention is best. What do we have out there that is a prevention that's offered through the pediatric office? Okay.
Can this be passed from mom to baby?
I think technically it can. If we have somebody who has genital warts, you know, it's up to the provider to know that in their history. And again, what do we know with patients with this kind of sensitive information? Are they always forthright about that? No. If they've been with that provider for a long time and they know they have a history of HPV, they will make a conscious effort to be looking when they're doing their weekly prenatal visits. But where we really get into trouble is our people with no prenatal care. I don't know, I would have to research if there's been any documented cases of maternal to fetal transmission. You would think because it's skin to skin, but again, it's gonna depend on where the lesions are. And if you think about it, this causes anything from genital warts to a plantar wart. So if you've ever had a plantar wart, your kid has a plantar wart, you know, maybe it's transmitted that way. I'm not 100% certain about that, but it's interesting to think about.
So the best chance of prevention is vaccination. So our youth, the kid, you know, the population that we talked about that is at risk. So before we get into the cancers, let's quickly do like a think, pair, and share. So just turn to your partner and discuss a few pertinent bits of information that you as the nurse would share with somebody of like a high-risk population to reduce the likelihood of them getting an STI. Sounds like you guys know all the answers. So does anybody want to raise their hand and share a couple of those?
Condoms. Okay.
Show me what I talked about.
Condoms, abstinence.
I used to work in a OBGYN's office, and I used to work the brochures, leave them all around my house. So that my daughter could see them, and when her friends came over, they could see them too. They would ask questions, and I would say, yes, that can happen. So, I don't know, they all seem to be healthy, so
Yeah.
maybe there's something.
Scare tactics.
So as a parent, if there's parents out there, okay, I mean, it might not be the, you know, the ideal conversation that we want to have with our children, but I know that I want my children to be hearing it from me, okay, and knowledge that is true, factual information. So it really is important to discuss with at youth, which is our risk population, definitely keeping them informed. So talking about how to use a condom, performing exams, like making sure you know what you look like down there, right? Like that's really important. We might kind of just forget about those things, and then like in that case, syphilis, you might not ever know that you had that primary stage. So knowing ourselves, limiting sexual partners, okay? Avoiding these at-risk behaviors. A lot of times when, you know, the at-risk population engages in this, they might be doing other things, drug use and multiple sexual partners. Making sure they promptly report signs and symptoms of infection. That's important to start treatment immediately. Taking all of your prescribed antibiotic if you do have one of these things. That's another important thing that a lot of people don't finish out. And then the most important that we kind of told you to highlight is making sure that both partners are treated, okay, and abstaining from sex until the course of the antibiotic has been completed, okay? All right, so cancer. Cervical cancer. Was there supposed to be a video first?
Oh, was there?
I don't know, did we miss it?
Did I write a video on there?
No, I think it's the next one. Okay. So highly preventable in most Western countries due to screening, tests, and vaccines. When found early and it's highly treatable, it's associated with long survival rates as well as good quality of life. So the HPV vaccine is prevention. Males and females ages 9 to 6 can receive the HPV vaccine. It reduces the likelihood of genital warts and may cause many cause the cervical cancer. Recommended for adolescents of 11 to 12 years of age as the first dose. Age 9 to 14 years at initiation. There's a 2-dose series. And at 15 years and older, there's a 3-dose series. I believe, yeah, there's the 1, the 2, and the 6 months. There's the intervals. They're 4 weeks apart, okay? It's really important through a pediatric office that they don't give that vaccine even a day early because it can throw the schedule off. So it's important to know those dates. Persons who have completed the valid series with any HPV vaccine do not need any additional doses.
So as long as you get that first shot when you're 26, can you continue on? Or no, because of the injury risk between the shot?
First shot when you're 26.
Because it's only good for 9 to 26 years, it says. You can only get it when you're between 9 and 26.
Oh,
So
yeah.
like if it's a multiple series vaccination, is it just that first shot? As long as you have it, you can keep going even if it takes you till you're 27?
Yes, yes. They just put that age cap on it because they're using
might-
statistics.
Yeah,
At
and
that
it could have been
point,
exposed by then,
right.
so.
By 26, they think that, you know, if you haven't already been exposed, that, you know, your risk decreases at that point of exposure. So that's just why they put the age cap on it. But yes, if it extended beyond the 26 years, you would be able to complete the series.
Maybe someday we'll see this as a mandated vaccine, you know, who knows. Cervical cancer screening, so we have the Pap test, and the cervical cytology screening. So almost always caused by the HPV. 21 to 29 years of age, every 3 years. So for 30 to 65 years of age, it's every 3 to 5 years. No screening is necessary after 65 years of age, with no history of a positive screen and a history of a total hysterectomy, for reasons other than the cervical cancer. Prostate cancer. So this video discusses some statistics regarding prostate cancer.
Prostate cancer is treatable, right? So what's the big deal? About 30,000 lives could be lost this year. That's for every 6 men in the US, one of them is going to develop prostate cancer at some point in their lives. When a man is diagnosed with prostate cancer, there's no way of knowing right away how serious the disease can become. And this year in the US alone, it's estimated that about 240
I want you to be able to hear about prostate cancer. This has been a thing.
Yeah.
Like the last 3 or 4 videos we've watched.
It does that?
40,000 new cases of prostate cancer will be diagnosed. What does the number 240,000 even look like?
Start this over.
About 30,000 lives could be lost this year. That's the big deal. And that's just in the US. But let's back up a little bit. For every 6 men in the US, one of them is going to develop prostate cancer at some point in their lives. When a man is diagnosed with prostate cancer, there's no way of knowing right away how serious the disease could become. And this year in the US alone, it's estimated that about 240,000 new cases of prostate cancer will be diagnosed. What does the number 240,000 even look like? It's huge. The Superdome of Louisiana can seat about 70,000 people. 240,000 is more than 3 Superdomes filled with our fathers, sons, brothers, and uncles who will find out they have newly diagnosed prostate cancer this year. The thing is, many men with prostate cancer really don't feel comfortable talking about it. And what about the thousands of men who die every year from prostate cancer? Let's put that into perspective. People always say flying is a pretty safe way to travel, especially if you compare it to driving. According to the most recent statistics, the number of men who are estimated to die from prostate cancer in the US is nearly the same as the number of people who die in a year in driving accidents. If cancers were in a competition, prostate cancer would win silver every year, as it's the second leading cause of cancer-related deaths among men. Here's some good news, though. If you take 10 men diagnosed with prostate cancer, 7 of them will have prostate cancer that doesn't come back after initial treatment. Unfortunately, for the other 3 men, the cancer will come back and can be life-threatening. These 3 men are our fathers, our brothers, and our sons. So how can we help them? By spreading the word to be proactive and knowing the importance of talking to a doctor to determine if screening is right for them. PSA, or prostate-specific antigen, may be measured along with other clinical tests. PSA is a blood test and used as a reference marker for prostate cancer. The PSA result is individualized and changes may be clinically important. When that number starts rising or symptoms appear, these men and the people taking care of them need to talk to their doctor about their options. Ongoing research is leading to new treatment options, especially in advanced disease. Who should be talking about this? Everyone. Tell your dad, your brother, and your uncle, and encourage them to be proactive in talking to their doctor about prostate cancer. The word is spreading and has already made a difference. The more people you talk to about prostate cancer, the more men we might be able to help. Do your part to help thousands and share this video with friends and loved ones.
So how do we screen for prostate cancer? Okay, we use the DRE, this digital rectal exam. Every man, every year, starting at 40 years of age.
50, sorry.
50 years of
Typo.
age.
I forgot to change that, it's 50.
A practitioner, so how it's performed, the practitioner inserts a gloved, lubricated finger into the rectum to examine the size of the prostate and feel for lumps or any abnormalities. There's the prostate-specific antigen, the PSA. This is a biological tumor marker. It is very controversial at this time. The American Cancer Society recommends that men thinking about getting this screening for prostate cancer, they should make informed decisions. We should be making those all the time regarding our health care, right? Based on the available information, discussing with their provider, their views for the possible benefits, risks, and limits of the prostate cancer screening. Some organizations recommend against the screening unless symptomatic. It should begin at the age of 50 with the DRE.
Why is it controversial? So, is it just like a false positives, or they're worrying people for no reason?
You see over here, I have the little graphic from CNN, a CNN report. It can be elevated due to other factors. Those factors are listed up there: age, race, certain medical procedures, medications, an enlarged prostate, which we'll talk about in a little bit, and a prostate infection. So it's not like a guarantee, especially if you haven't been having it checked at regular intervals, okay? If you have a high PSA, what they usually will recommend is a prostate biopsy. So that's where the controversy comes in, because a biopsy, removal of a piece of tissue, can have some complications in and of itself. Those complications are listed over on the side: blood clots in the legs and lungs, some cardiac problems as related to that blood clot, and impotency or difficulty controlling urination. Obviously, that depends on how much tissue they take, the method, if they do it through the rectum, if they try and do a transurethral biopsy, okay? So that's where the controversy lies, is PSA is not a definitive diagnostic tool. You need to undergo other things that could possibly have negative effects. So the video is a man who received an elevated PSA and it was cancer, so it's more like a public service announcement. So this slide serves as the controversy point, the negatives of possibly getting a high PSA and undergoing further testing that's not necessary. And then the video is somebody who the PSA basically diagnosed their cancer for them. So there's two different schools of thought. Obviously, it's going to be based on your provider's recommendations and any other opinions, from the medical community that you might get or choose to receive.
If you ever needed a poster child to show that the PSA test is effective and worthwhile, it could be me. When I was 52, I scheduled a physical, and at the time I felt perfectly healthy and reasonably active and fit. I really didn't have any health problems. I wasn't taking any medication. The doctor came back and said, everything looks great, except this PSA is a little bit high. We better check that out. 10.7. And when I went home, I did some research on 10.7 and was really quite alarmed.
You're talking about a disease that has a definite chance of killing you. Prostate cancer is virtually incurable when it has left the prostate, spread through the bloodstream. It is a very painful, miserable experience for patients. It doesn't kill quickly.
Unfortunately, it was 2 days before my daughter's wedding, which kind of gave me a different outlook at that wedding.
The U.S. Preventative Services Task Force suggested or recommended against PSA testing for the average middle-aged and elderly man.
Gonna be a little pinch, okay?
They overstated the harms of PSA testing, understated the benefits of PSA testing. In the mid-1990s, 42,000 men would die each year from prostate cancer, and now it's about 28,000. So we tried to figure out what would happen if we went back to before PSA became an approved test. We looked at how many people would come in with metastatic prostate cancer, then you would increase the numbers from 8 to 25,000 men per year. That's because the PSA test allows you to detect the disease before it's had a chance to spread.
I'm much happier that I came in with a PSA at 10.7 than wait to have symptoms, where then the treatment options are so much more limited, and I don't think they're as life-saving.
I see patients who are diagnosed with prostate cancer because of an elevated PSA on an everyday basis. Some of those people have a small focus of indolent cancer where treatment is probably not needed. And some have very aggressive cancer and large volumes of it where it makes a very big difference that you caught it early rather than later, and this is a very common event.
I knew I needed the right treatment soon.
The subsequent test that PSA leads to, if it persistently is elevated and the patient agrees, is a prostate biopsy.
They did the biopsy and it proved that I did have prostate cancer. It was a grade 6 tumor that most likely should be operated on.
The patient can decide whether they want to be treated and actually choose from a menu of options for treatment.
52 years old and good health, he recommended that I do a prostatectomy instead of the radiation at this point. I know over-treatment can be a problem in some patients, but in my case I was happy to go through with it and get on with my life. I've gotten past all the problems that were associated with the surgery after 6 months or a year, and it's almost like I have had no change. It was more of a speed bump in my life instead of a real problem.
Detecting prostate cancer early has allowed us to reduce the number of men who have died from prostate cancer enormously. Most men who are faced with this question would wind up choosing, I should have the blood test.
If I hadn't had that PSA test, I'm not sure this would have been caught early enough to be treated successfully.
So you have the two different schools of thought there, okay? Do you have enough time? Sorry, I'll be done.
Right. My cold, I got like this itch in my throat. So I'll finish up with breast cancer. Sound horrible. I don't know if you want to hear me on this loud thing right now. Good. Okay. So breast cancer, the risks. Defects in cancer genes, 1 to 2, so the BRCA 1 to 2. The female gender is 100 times more likely to have breast cancer. There can be a family history that contributes, excessive weight, alcohol use, exposure to carcinogens, and advancing age. So screening for these are clinical breast examinations, the mammogram, and a self breast exam at home.
We're going to do the SBE activity before we go on to the SBE thing.
Okay. All right. Yeah, I know my throat. Okay.
So we're going to have you turn to a partner again, or you can work in groups, but the next slide is talking about self-breast exam. So it's kind of, some of it was covered in your reading. Do you want to come up, Kelsey, and do that for everyone? Things have changed over time, so it's not just the feeling for lumps. There's all sorts of different movements that you're supposed to make. But I want you to kind of develop like a mini teaching plan for a patient if you are instructing them on a self-breast exam, okay? So what I want you to be able to tell me is the major points that you would hit, the key things that they should be able to know to effectively do a self-breast examination on themselves, okay? You can work in as little or small groups as you want, and I'll give you about 5 minutes to do that, and then we'll come back together and share, okay?
That was surprising.